Good morning. Thank you for joining us. Obviously nobody's here yet, but as people catch up, maybe they'll catch this. My name is Brian Ullman, Communications Director for Idaho Freedom Foundation, and today we're going to be watching the Medicaid Managed Care Task Force Committee meet. Our own policy analyst, Niklas Kleinworth, will be testifying in front of that committee in about half an hour, maybe a little longer, depends on how long they go. This might seem to be a dry subject, but it is something that I think is important to keep an eye on. Medicaid represents the biggest single chunk of the state budget. So what, $4.6 billion out of a $14 billion budget. Medicaid expansion passed by the voters in 2018 has a big part to play in that. But overall, it's just, the program is expanding. It's, more people are getting on it. Costs of drugs are going up. And anyone who takes first-year economics, you will learn that the more people, the more organizations, the more layers are involved in a transaction, the more expensive that transaction eventually is going to be. When it's just you taking out your cash and giving it to a service provider, such as a doctor, there's nothing in between you, and so you are paying for services rendered. You start adding in layers, insurance, government, and now there's these extra layers, and those layers cost money, and that drives up the cost. Third-party payers always increase costs. That's basic economics. So once you have Medicaid in, government involved in medical decisions and in healthcare, that is by definition going to raise costs. So the whole issue here is that the state is looking at the cost of Medicaid saying, well, these costs are too high. So what can we do about it? And they commissioned a report by a firm called Sellers Dorsey that essentially suggested moving to a managed care model. And as I understand it, it's basically more like an HMO. If you remember that from 15 years ago, that was a big debate as a lot of insurance companies were moving to managed care. Instead of you going to your doctor and then billing insurance, instead your insurance has a group of doctors, sometimes even in one building, that you then go and see. And it does smooth out some of those layers I was talking about, which could theoretically reduce costs. However, what Niklas is going to present to the committee is that that's just, essentially whistling past the graveyard. It's papering over the bigger issues. He's got some data to show that managed care in the other states that have tried it has not really controlled costs because it's ignoring the real drivers of cost increases. So I'm not the policy expert, I'm just the communications guy, so I'm not going to go too deep into that. I'll let the experts tell you about it. But in just a few more minutes, the presentation is going to start, and I will switch over there so you can watch it with us. Niklas, like I said, will come on in about half an hour. He's scheduled to be the first presenter, which is great. Get the committee members while they're all still awake. By the way, if you're just joining me, go to idahofreedom.org, click the big banner in the at the top of the website here. I'll show you. idahofreedom.org. See that big banner, special report, Florida's blueprint for conservative K-12 education? Click that banner, and it will take you to a page. You can put in your name and email, your zip code, so we know who your representative is and what might be important to you. And you will get a free copy of this report in your inbox. It's the full PDF copy, nothing, no excerpts, nothing kept out, and it can help you see how one state is doing the work of rooting out the critical social justice ideology in K-12 education. A few years ago, we, Idaho Freedom Foundation, released a report on Idaho's K-12 education and shows where the problems are. Well, here's some solutions. So go to idahofreedom.org and you can pick that up. So, let's see. Looks like they haven't started yet. They've got the committee room here, and it is people are still milling about. You know how these things go. If you've ever gone to a committee, there's, especially when the legislature's not in session and there's not, a super strict timetable to get back to the chambers, they'll be taking their time. there's a lot of stakeholders. That's what they call them on the sheet, stakeholders, people who have an interest in testifying before this committee about the pros and cons of this managed care plan. And so after Niklas, there's going to be a lot of other people who are going, and we'll keep it streaming. I won't always be here. I've got to step out and do some other stuff, but I want to be here at least until Niklas testifies. Make sure to record that so we can promote it. We like sharing what our team is doing. IFF really is a multifaceted organization. You know about the Freedom Index, where we rate every bill and then lawmakers generate scores as they vote on those bills. I think that's an important tool for keeping your legislators accountable, especially when they come back to your towns and your cities in the off season and beg for your votes, promising that they're conservatives. Well, we give you the tools to see whether that's true or not. In addition to that, we also do a lot of policy papers, research papers like Education Policy Director Anna Miller's Florida report and the Idaho report and various other reports. Niklas Kleinworth is our policy analyst. He does a lot of work on budgets, and especially as they relate to healthcare, so this is right up in his wheelhouse. Fred Birnbaum is our legislative affairs director. He does a lot of work with numbers and budgets and high-level issues. Ron Nate, former Representative Ron Nate, he is our senior policy fellow. He's teaching economics over at BYU Idaho, but he also, during the session, he's here in the office every day, and he's writing papers for us on various issues. And of course, Wayne Hoffman, the boss, the president, the CEO, the head honcho, the big kahuna, he's doing everything everywhere all at once. He's writing, he's driving the conversation, he's pushing the high-level ideas, he's traveling the state, meeting with donors, meeting with supporters, meeting with various other political figures. So yeah, we've got a lot going on, and we're happy to share some of it with you today. We're still waiting for the committee to get started. They've got a few people queued up on the Zoom, it looks like, and the room is still filling up. The doors are still open. I guess I'm drinking this backwards, so let's see, Idaho Freedom Foundation. Hope you're all having a good Wednesday and a good week. It's been a few days of respite from the 100+ temperatures here in the Treasure Valley. It's been pretty hot this summer. It's only been in the 80s and 90s these past few days, with a couple thunderstorms thrown in for good measure. It's looking like it's going to get hot again, though, through the middle and end of August. But I hope you're all staying cool and safe out there. Let's see what else is going on. No comments yet. If you have comments, I should be able to see them. So drop them in here on YouTube, Facebook, Twitter, or X, I guess as they call it now. By the way, if you're not following us on social media, you can find us at Idaho Freedom on Twitter, or X, as the case may be. You can find us at Idaho Freedom Foundation on Facebook, find us on YouTube. We're on Rumble. We've got a Rumble channel. We actually have a couple of videos that were erased by YouTube last year during our Capital Clarity session. By the way, Capital Clarity will be coming back in the next legislative session starting in January. Every Thursday at noon, we meet in the Lincoln Auditorium downstairs in the Capitol, and we bring you state government officials, lawmakers, and other interesting people who have interesting things to share. And we start a conversation between them and the people. Anybody's invited. You can come join us at the Lincoln Auditorium, 12 noon on Thursdays during the session, or join us on all the aforementioned platforms. Anyway, last year we had Senator Tammy Nichols and Representative Judy Boyle presented their bills that would have banned mRNA vaccines. Now, whether or not you support banning mRNA vaccines, the point is this is legislation that was proposed by our lawmakers, and they wanted to tell the people about it and why they did it. Of course, YouTube does not like anybody saying anything the slightest bit negative about mRNA, so they trashed it, gave us a warning. Anyway, it looks like we're about to start over here. I see the co-chair of the committee, Senator Van Orden, looks like she's corralling people, getting folks ready. I still don't hear any sound yet. So make sure my sound settings are all good. Oh, there we go. All right, I'm going to flip over to her.
Testify, they can't come back after lunch. If you would let us know so that we can put you on the agenda for this morning, and then we'll move other people down. So is there anybody in the audience that would not be able to come back after lunch that's presenting this morning on the agenda? You would be the later people. So okay, great. So it looks like everybody will be presenting. So at the end of our meeting, we'll do some wrap up for our up and coming meetings for later. Make sure you have your calendars out, committee members, so we can schedule for the next couple of months. We will have a timer come up on the screen for our presenters too. So Soren upstairs will be presenting, will be timing so that you'll be aware of your time limit when you get up to present. That will be up on the screen starting after our first presenter. So with that, we do have minutes that we need to approve. We have the minutes of our July 10th, 2023 meeting.
Move
Co-chair?
to approve the minutes from July 10.
It's been moved by the co-chair to approve the minutes, seconded by Senator Wintrow. All those in favor, say aye.
Aye.
Any opposed? Thank you. I'm going to turn the time over to my co-chair if he would like to make some remarks about today.
Thank you, Madam Chair. And just for everybody's information, we're still gathering information, and we're looking for solutions. So as you present, we're not looking for complaints. We're looking for solutions. So as you take your 5 minutes, if you can come up with some really good ideas that none of us have thought of, or that you like, that we may not like, but just remember, we're according to the concurrent resolution, this is to try to look at the cost of Medicaid and how to control the growth of the cost of Medicaid. So just keep that in mind as you present and as we ask questions.
Thank you. Okay, we are going to start our presentation with Dan Lillenquist from Intermountain Hospital, and he is with us online. Welcome to...
Thank you, Senator. Can you hear me?
Yes, I can.
Okay, perfect. Well, I thank you for the invitation to be here today. I wish I could be there in person. I'm in California at a conference, and thank you for accommodating me. My name is Dan Lillenquist. I'm the Executive Vice President and Chief Strategy Officer with Intermountain Health. And Intermountain is a large integrated delivery system based out of Salt Lake City, Utah, but we also operate up in Idaho. But I think the purpose for inviting me here is I'm a former state senator in Utah and actually ran the legislation in 2011 to create Utah's managed Medicaid program. And my understanding, well, maybe I'll take just a couple of minutes explaining how we've approached this in Utah and then answer any questions maybe the committee might have for me. I took office in January of 2009, was sworn in 2 weeks early. We were at the trough of the Great Recession. And 5 minutes later, I sat down in a committee room, much like the one you're in today, and with the task of trying to figure out how to take 16% out of our Medicaid budget mid-year. And the tool set at the time was we were very limited. The majority of our Medicaid program was what we termed mandatory spending. It was really hospital-focused, hospital and provider-focused spending. And our tools were essentially to cut services for those with disabilities and substance abuse programs, respite care for families with disabled kids. And that was an awful situation. So I resolved at that time we were going to try to find a way to cap Medicaid spending to figure out how to put this on a better trajectory for the state. When I graduated from college in 1998, Medicaid spending in Utah was 9% of the state general fund. By the time I had taken office 11 years later, it was 18%. It was projected to be 50% by the time by 2020. And so we worked over the next couple of years trying to figure out what to do. And I'll just, in a nutshell, tell you kind of the legislation that we ran in 2011, how it works. We passed legislation in 2011 that did four things. One, we capped Medicaid spending on a per member per month basis to the growth rate of the state general fund. It's the first thing we did. At the time, Medicaid, our tools to manage Medicaid spending were poor. Essentially, most of our Medicaid patients were getting their primary care in an emergency department because, essentially access was really, really poor. The first thing we decided to do, again, was cap Medicaid spending to the growth rate of the state general fund. And then two, the second thing we did, we said, look, we are going to take the money that we've committed to spend, and we're going to try to make sure it makes it to the providers that provide the care in a way that rewards people well. The challenge with previous managed Medicaid, which we had tried in Utah before, was every time a provider intervened to keep somebody out of the emergency room and go to a primary care office, the state would come back and say, well, they weren't that sick to begin with, and would try to essentially repatriate the savings back to the state. So it gave a disincentive to actually manage Medicaid patients, because every time you did, when the rate setting was done the next year, Milliman would come in and say, well, the people that they were caring for just weren't as sick as the previous year based on the claims data. So we agreed that with the cap, we would also ensure that the payments would flow through to the providers. We used a system where we use health plans who have the tools and capabilities to actually process claims and effectively manage the utilization management side of the Medicaid program to help administer this the Medicaid ACO in Utah, but with the goal that any provider payments that made it to the providers would count towards the medical expense trend. And that's really important in this respect. Medicaid programs can be rebased over time. When you work to keep people well, again, it looks like they're less healthy or less ill. And if you're just going off of claims data, what it allows the actuaries to do is to lower the payment for providers. So when we agreed to put in the cap at the state level, we essentially locked in billions of dollars of savings for the state, but then agreed that we would commit to the ongoing funding of Medicaid, and it's averaged around about 2% increases in Medicaid funding each year, lower than overall healthcare inflation, with the expectation that if the providers did a good job of keeping people well, that they could make margin and make money on the difference between the capped rate and what it costs them to provide that care. That was really, really important, because when we sat down with the providers with their legislation, they just said, yeah, you're going to put this cap in, and then in addition, you're going to take money off the table. And we agreed that we weren't going to do that. So the way we agreed to work with the providers, again, I think this is a really important point as you consider the policy in your state, is that we would count the underlying claims data plus any payments that made it to providers towards the medical expense trend. which allowed us to essentially agree that we were not going to rebase the contract. We were not going to artificially lower the payment, that the cap on the Medicaid growth rate was sufficient. So that's the second thing we did to commit. The third thing, we committed that we were going to focus on quality outcomes and patient satisfaction. And that was really important. We wanted to make sure that if we were prepaying providers to take care of people, that they were meeting the needs of those people and keeping them well. And then the fourth, we agreed that we would, in the Medicaid ACO program, that we would not have our Office of Inspector General go in and question all the care that was provided. We felt like we had enough controls on the growth rate and the quality that we did not need to go in and re-engineer the whole program. We wanted the market to work. We wanted creativity and ingenuity to emerge so that we can have new models of care. So that's what we did. I'll just summarize four things we did. We capped Medicaid spending to the growth rate of the state general fund. Second, we agreed that we would not rebase the contract with our providers, that the cap was enough for the state, that it would lock in billions of dollars of savings, and that we would not over-engineer the results underneath. As long as payments made it to the providers, we would count that towards the medical expense trend. Third, we implemented a quality program and a customer satisfaction program that ensured we had the right access. And fourth, we said we would not have the Office of Inspector General for the Managed Medicaid program go in and conduct detailed audits of how that works, because again, we felt like the incentives were aligned. We passed that legislation. It actually passed unanimously in 2011. It took us 2 years to get the Obama administration to give us the waiver to implement it, but we implemented that program. And Utah has had a very stable Medicaid program since that time, and we're now 11 years into that. So I guess really 10 years into that program. So with that, I think I've taken my 5 minutes. I'm happy to answer any questions you might have.
Questions? Senator Wintrow.
Thank you, Madam Chair, and Mr. Lindquist. Thank you, our former senator. Thank you for that presentation. Really sounded great. As you made the transition, what are some of the particular challenges that did surface that you had to address?
Probably the biggest challenge we had to address, the advantage of having the cap in place, what would happen at the legislature every year is people would come up to us and say, well, you know what, you just got to increase funding on Medicaid. And placing the cap really helped us. Essentially lifting the cap would have generated such a huge fiscal note that instead of being lobbied every year for a massive increase in Medicaid rate, that just wasn't really an option. You would have had to add a huge fiscal note. But what that did, though, is it presented problems where you might have a new mandated treatment. So, for example, there was a year when I believe it was the drug Sovaldi came out, which is a hepatitis C drug, massively expensive drug that came out that was unanticipated. And so we had to create a kind of a relief valve for what we considered exogenous shocks to the program, unanticipated significant cost increase. There were a couple of pediatric drugs that did the same thing. You have too many of those layered onto a managed Medicaid program, it collapsed the program altogether. And so what we did was we created a safety valve that when there were specific issues like that, we could on an exception basis work with the Medicaid department to kind of reset the floor. That was probably the biggest thing that has been of concern. There's risk adjustment concerns with Medicaid as well. We have a kind of a rate cell structure in Utah, and occasionally, you'll find a certain number of people with a certain condition who will aggregate in one plan over another, and that creates kind of inequities across the health plans. And so we've had to, over the years, adjust rate cells based on, for example, if you have one provider with all of the cystic fibrosis patients for the state, and your rate cells in Medicaid are not resilient enough, you could have one provider disproportionately taking on the burden of and the cost for a certain subset of people. So over time, we've had to adjust rate cells, but we usually do that directly with the state Medicaid program, and that's worked itself out over time. But by and large, we haven't run into serious hurdles. There are things on the margins that we've had to come in and adjust to make sure that the program didn't become unstable. But the overall frame has held up really, really well. Did that answer your question?
Follow up?
Thank you, Madam Chair. Mr. Lindquist, thank you so much for that explanation. And finally, just one other question. So I think one of the complications in Medicaid and inflation costs are rate reimbursement rates, right? So the providers who are providing and contracting for services in the community, I think would regularly say that the rates are not being increased according to inflation, and that there are some businesses now that are subsidizing or being expected to subsidize payments, and they just can't take more Medicaid patients, right? Because it's just too hard to their business. So tell me how you all work to create a system that kept the rates where they needed to be, but then didn't bankrupt the system. Because I think the tension for us, honestly, is sometimes we will do a rate reimbursement and we want it to get it to the workforce so we have appropriate and qualified staff. And what I'm seeing is that some people are going independent, so they take out an agency provider in that process. So I think we're really struggling here in our state, in my estimation, on how to do the rate reimbursements and then how a managed Medicare system could help with that.
Mr. Lindquist.
That is sorry.
You're fine. Proceed.
Thank you. I know I'm supposed to go through the chair. I know the rules, so thank you. Excellent question. And what we realized, that is the $1 million question. How do you rebalance rates? And look, my brother's a diabetes specialist in Idaho Falls. I grew up in Idaho Falls. My other brother's an orthopedic surgeon out there. I'm an Idaho boy at heart. And that is the real challenge. And what we found in Utah was when you just repair blanket rates overall and kind of spread that in peanut butter style across the rate structure, it doesn't actually improve access. In fact, what we found was, again, most of our people on Medicaid, because they could not get into primary care, were going to the emergency department for care. Very expensive, ineffective, gummed up the works at hospitals across our state. When we capped Medicaid spending and then worked with payers to actually help administer it, what we saw almost immediately is those payers, because there was a cap program, started to rebalance how payment was made to providers. In fact, Select Health is a good example. They almost immediately started repairing rates for primary care doctors to see Medicaid patients. And because it wasn't set at the state level, but it allowed the plans to come up with incentive programs, et cetera, to have a primary care provider open up their panel to Medicaid patients, that allowed that rebalancing of payment. And there were plenty of funds we found. It felt like there were plenty of funds to actually encourage primary care doctors to open up their panels to Medicaid by repairing some of those primary care rates. Now, it did come at the expense of emergency department usage, but that's what we were trying to avoid anyway. And so we found that allowing providers and payers to work together, that we were able to rebalance some of that inefficient payment. We also found that look, it is really hard if you're a standalone primary care practice and you're trying to balance keeping your doors open. If Medicaid gets too far behind, you cannot afford to take Medicaid patients. And that then shifts the cost to the hospital. So our experience has been that if you do this the right way, you can repair primary care rates. It's so much cheaper to have somebody go see a doctor in a doctor's office than an emergency department stay. That's been our experience in Utah. We needed to give the creativity and flexibility to the plans and the providers to figure out how to do that, and that's worked for us. Now, is it perfect? No. But we have much better access now for Medicaid patients in primary care in Utah than we did 10, 12 years ago.
Representative Tanner.
Yeah, thank you, Madam Chair. You had talked about the cap and then this large appropriation if that were to go away. And that's kind of what deterred anybody from kind of going after that. What kind of dollar amount are you talking in that large appropriation?
Mr. Lowenquist.
Thank you. Thank you. So for us, I mean, when we put the cap in, we estimated that it would save the state of Utah $2.5 billion over the first 7 years of the program. And so if you lifted the cap, we had a pretty good sense of, what the state funds would be required to cover that. And it was hundreds of millions of dollars for the state portion. And so really, when we worked with our fiscal analyst's office, it was clear that if somebody wanted to lift that cap, it would just be too hard to lift. And you know how it is. If you have somebody who shows up and they've got an ongoing fiscal note about, $150, $200 million, it's just really, really hard to get that done. And so what that did is it changed the conversation around, you just got to pay us more money to how can we work together to make sure the program works? And that was by design. We just realized, like, until the state of Utah said, we're serious that the bank is closed and here are the rules, there are myriad different ways that people would get payment increases through. And it was usually, we were not getting the creative solutions we need to solve the problem because the back door was always open to get more state funding. So that's how we did it.
Follow up.
Yeah, follow-up, Madam Chair. You had talked about the kind of an incentive that would come back to the providers and the hospitals when they're doing more healthy type, providing more healthy options or getting them healthier, and we're not seeing them just going straight to the emergency room. Can you speak to some of those, how that kickback and how that, how you guys were doing that?
Yeah, so this is really important, maybe the most important thing that we did. I explained kind of how if you just have a program, most Medicaid programs, when they're evaluating whether or not the Medicaid program is fairly compensating people, they'll bring in a middleman and they'll only go off of claims data. So again, if you keep somebody well, it doesn't look like they're sick. So if you somebody avoids getting type 2 diabetes because you're actively managing the disease, it's really easy after the fact for an actuary to say, well, they weren't that sick to begin with, even though you've been working to keep them well. And so we just realized early on that we couldn't just have an actuarial look back to judge how we pay providers. But we agreed that if there was, obviously you have claims payments, but any provider payments that made it to a provider, that weren't just stuck at the health plan, that made it to a provider would count towards medical expense trend. And that was really important. That's kept us right with Milliman, and it's kept the program from rebasing. But here's what we didn't do. We didn't come and say, we're going to set a state mandated incentive program. We allowed the plans to develop their own programs, and as long as that payment made it to a provider, then we were okay with that. And we wanted creativity and ingenuity to emerge here. So if you have a particular community that didn't have primary care access, we wanted the providers and the payers to work together to figure out how to fix that access. We didn't want to mandate that from the state. Again, think of this as we set the rules and we wanted the market to prevail and kind of free market principles to emerge. But I tell you, the other thing that we're really concerned, we watched other states do this. It's really easy for the state to declare a managed Medicaid program and work with a national payer, for example, and have that national payer siphon off profits out of the state and not actually have those payments go to providers. And you see this across the board. You see this in Nevada, for example. In Nevada, the admin rates that are being pulled out by the Medicaid programs in Nevada are pulling out almost $500 million of payments that should be going to providers out of the state that are just padding the profits of the national payers, frankly. We wanted to avoid that in Utah, and so we were very, very clear that we wanted to work with payers because they have tools that providers don't typically have in managing kind of an overall population and reaching those populations effectively. And most providers, especially if you're a small provider, you don't have the ability to do that. But we insisted that those payments make it to providers. And we've been very carefully observing that because we wanted, if the worst thing to do is to set up a managed Medicaid program, give that contract to a national payer, and then they siphon off funds out of the state that don't go to care for your people. And so we've been watching that really, really carefully, and setting up that incentive has allowed those payments to stay in the states and go to providers, which has helped repair, as the previous senator mentioned, repair rates for primary care and other area access points. And that is a fundamental piece of this reform we did in Utah. We wanted to make sure the money stayed in the state. We wanted to make sure it was making it to providers who are actually providing the health care, and that there was a balance between what the health plans would make on the program and what went to providers to ensure there was appropriate access for these Medicaid patients. Does that make sense, and did that answer your question?
Yes, it did.
Okay.
He's nodding his head over there. Okay. Co-chair.
Thank you, Madam Chair. And just a couple of quick questions. When we talk about our budget here in Idaho for Medicaid, we say the argument I heard this past year was it doesn't make any difference what you set your budget or your cap at, because if we set it too low, they're just going to go for a supplemental. So how do you work that out when you set the cap of the spending according to the growth of the general fund or the state's income? So how do you go back?
I may have lost you. Can you hear me?
Yeah, we heard you.
We can hear you.
Oh, I'm sorry. My
how do
connection
you
was
set that
unstable for
cap?
just a minute, Representative, but I'm back. Go ahead, please.
Okay.
So how do you set that cap? You came in the same time I came back when we had to start cutting all the budgets in 2009, and the revenue in the state dropped a third, and we had to make cuts in the budget. So what do you do with Medicaid if it's tied to the general fund or the state's income? What do you do if if we go into a recession and the state income drops 10%? Do you then cut 10% out of Medicaid?
Mr. Lundquist.
Yes, thank you, Madam Chair. I apologize. One thing that I neglected to mention, and this was another really important thing of the reform, we had just gone through 2008, 2009, and in placing the cap, we knew we would have good years, and we knew that the state, we were not obligated to fund Medicaid at the full growth rate of the state general fund. It was capped at that. So in the years we had, 4 or 5% growth rate, we didn't fund Medicaid at 5%. We funded it typically around 2.5% to 3%. But what we did was we agreed that we would create a Medicaid stabilization fund in the good years that would put funds away and put them aside so that when we had downturns, we know we would have them, that we didn't have to gut the program, that we would have some float to keep us steady through those through those times. And what's unfortunate about Medicaid, it's totally counter-cyclical. So you go into a recession and your Medicaid rolls just, explode. And what we wanted to do is, as best we could, is prepare for those rainy days by creating essentially a rainy day fund for Medicaid rates. And we put money away in the good years to kind of soften those times when the Medicaid rolls would expand. And that has also helped us stabilize things. So it takes discipline in the good years to put money aside to kind of smooth out the bad years and build a rainy day fund. And that was an important aspect of what we did. What we didn't feel like was going to be effective is if we knew something like that was likely to come down the road, to not plan for it was negligent on our side. So that was a key portion of what we did as well. So we were able to set funds aside. Gratefully, we've not gone through anything quite like the 2009 Great Recession since, but yes, that's the other thing we did to kind of stabilize those rates. If we had funds put aside, we wouldn't have to overreact and pull away funding all at once for a program that we hope to be stable for the long run.
And follow-up?
Follow-up?
Thank you, Madam Chair. And a couple of follow-ups. You stated that you didn't want a national organization coming into Utah and bleeding off some of your Medicaid. So did you put stipulations in there that your ACOs had to be local or had to be state-based? How did you go about picking I believe you have 4 ACOs that are statewide, but how did you legislatively put that in, or how did you go about on that process?
Mr. Lillenquist.
I'm getting the rules down, Madam Chair. Thank you. So, look, we allow nationwide Medicaid providers to bid for business in Utah. Molina is one of them. But what we were careful to do is to make sure that we were really tightly managing, and we've been working on this, to make sure that the funds go to providers. There's an appropriate admin fee that needs to come out, but really the focus has been on making sure that we weren't allowing a mechanism for payers of any type. Now, you can have the in-state payers do this as well, any payer to siphon off funds, because we wanted those funds to go to the providers. So we did not mandate. In fact, what we also did not do is we did not award a statewide contract to one payer. We said, look, anybody who wishes to bring forward a Medicaid ACO is welcome to do that in Utah and compete for the business. And gratefully, we had 4 ACOs step in to do that. Again, one of them being a national player in Molina. We also felt that was important for different models to emerge. But the key thing we focused on, Representative, was making sure that that the profits of this program, that there wasn't inappropriate profit taking at the payer level, that the payments were actually flowing to the people who provide the care to improve the access and make sure that we, as we funded this program in Utah, that it was going to people as much as we could ensure was going to the people who are providing the care directly.
Okay, one more follow-up.
Follow-up?
Thank you, Madam Chair. One more follow-up. Since you started your program, what has been your average cost per individual as you've gone through the process?
Mr. Lillenquist.
Yes, thank you, Madam Chair. So the average cost has been below 3% on average, because again, we're capped at the growth rate of the state general fund on a per member per month basis. And so that is materially below general medical inflation. And again, with some of these tools, our providers have largely felt like they're able to be creative about how to keep people well. So as far as the overall budget, as you know, with Medicaid redetermination, with all the different programs through COVID, et cetera, the numbers have fluctuated quite a bit in Medicaid. But on a per person per month basis, per enrollee basis, it is abided by the cap we placed, and it's been below. I believe it's below 3%. It may be closer to 2%.
Follow up on the follow-up.
Okay.
Thank you, Madam Chair. So what is your average cost per member? What's the latest data you have now of your program? Because I've heard that you're higher than us, so I'm just curious.
Mr. Lillenquist.
Yeah, so I don't have that answer for you today. I don't, and I'm not. It'd probably be best, so we could probably get our Medicaid director from Utah to address that directly, and that may be something you would consider doing. I will say that Utah over the years, and this has been for the last probably 30 years, has been really deliberate about trying to keep Medicaid rates close to Medicare rates as much as possible. And when I joined the legislature in 2009, that mentality had been in place for some time. because we were very concerned about the cost shift between commercial and government payment. And we're trying to make sure that we were not imposing a hidden tax on employers in Utah by underfunding Medicaid. So Utah's Medicaid program as an overall program, as far as the percentage of Medicare, is one of the higher in the country. But that has been a long-standing policy in Utah, and again, predating me by decades, to try to make sure that we were not passing a hidden tax onto our employers in the state through aggressive cross-subsidy. Now, that said, there has been a gap that's opened up over the few years between Medicare and Medicaid funding in Utah, but I'm representative. I don't know exactly what that gap is.
Okay. Thank you, Mr. Lillenquist. We thank you for being with us today. And
thank you for having me.
And sharing. We're out of time with him. Okay. Sorry. We are going to stay on schedule, and we've made sure that everybody gets a certain amount of time. So I know there's questions. There was a lot going on there with Mr. Lillenquist. There are, I think, representatives in our state that could talk to you probably more about what's going on in Utah, or put you in touch with him at this point. All right, thank you. We're going to start in with our stakeholder comments, and like I said, we'll give 5 minutes to each person, and then we'll give 5 minutes for question and answer from the committee. So make sure your questions are brief and precise. And anyway, we'll get started. The first one we have here is Niklas Kleinworth from the Idaho Freedom Foundation. If you could identify yourself for the record. Oh, hang on. I have something. Most of the presenters, we're probably going to have your timer on screen, but for PowerPoints, along with, we can't have a timer on the screen. So we have our secretary, our committee secretary will be timing our presenters. So Niklas, she's explained to you what's going on. So welcome to committee. Please identify yourself for the record. Is that microphone on?
No, you gotta turn the microphone on.
There it is. Okay. Welcome to committee.
Good morning, Madam Chair, Mr. Co-Chair, and members of the committee. For the record, my name is Niklas Kleinworth, and I'm a policy analyst for the Idaho Freedom Foundation. Despite 35 states covering more than half of their Medicaid population under managed care, spending in the program grew by $146 billion between 2017 and 2021. If the goal of this committee is to finally put Medicaid on a sustainable budget, managed care misses the mark. Nationally, managed care demonstrated lackluster performance in controlling medical welfare spending across the country. Among states that covered at least 50% of their population by comprehensive managed care programs, there was no significant distinction between managed care states and the rest. Overall, states appear to end up in the same place, regardless of whether they used managed care, growing Medicaid costs with little control. There are many examples of states with managed care, like Louisiana and Georgia, and without, like North Carolina and North Dakota, that range across the spectrum of cost growth. Now, Sellers-Dorsey reported Nebraska and Utah as model states for Idaho to emulate, but both states did not see lower costs due to managed care programs. Utah's total Medicaid spending was virtually identical to Idaho's at a much higher cost per beneficiary. Utah's spending per member per month grew more than 2 points faster than Idaho at a compounding rate of 6%. In Nebraska, we see a very similar story. Nebraska saw a much higher cost per beneficiary And pre-COVID and expansion, the annual average cost per beneficiary was 16% higher than that in Idaho. Managed care did not appear to contribute to improved budget stability either. Both Nebraska and Utah had to pass supplemental appropriations to cover the costs of their Medicaid programs. The chart shows how spending in most states is moderately predictable regardless of the management system. In all, managed care has no cost control because it ignores the main drivers. In all states, Medicaid expansion was the strongest driver of budget growth. In Idaho, this program costs about 2.5 times more than what Millman predicted it would cost in 2018. Prescription drug use drives costs too, with claims outpacing enrollment by 50%. Though the prescription drug benefit is optional, Idaho has little autonomy for what should be covered. Ultimately, we are left with record spending on a population dependent on government for drugs, particularly for mental health. There also exists a pseudo-expansion for ineligible enrollees. A DC news outlet noted that Idaho is one of 9 states that agreed to stop removing people from the rolls for procedural redeterminations. The legislature should demand an answer from IDHW about this and how the department intends to finish the pandemic unwinding on schedule in December. Thirdly, provider billing practices demonstrate a lack of integrity in the system. CMS data reveals that 2 in 5 payments made to Idaho providers are improper. This is about $1 billion. Even if most of these are simple errors, this brings up some serious questions about billing practices. Currently, there's a data gap in this area that requires investigation into how much money we're actually losing. So what should the Idaho legislature do to address the rising costs? The solution is simple. Idaho must address the 3 components of an iron law. First, Idaho must expeditiously remove ineligible enrollees from the program and repeal expansion. This addresses the fact that Idahoans were undersold on the cost of Medicaid expansion and preserves the program for the truly needy. There also must be efforts to address service costs. There should be a full forensic audit to identify how providers are billing for Medicaid services and where improper payments could be prevented. Finally, there should be more accountability for service use. The state should push back against CMS's all-or-nothing approach to Medicaid prescription drug policy. This may entail a change to offer the program for the truly needy at the state level instead of from the federal top-down. To summarize, switching to managed care will not be the solution to Idaho's Medicaid budget woes. The system does little to control budgets, necessitating a return to the iron law of Medicaid cost control, reducing enrollment, reducing use, or reducing service costs. Otherwise, you can expect that we'll have the same conversation in this committee room 3 years from now with taxpayers still facing insurmountable costs. Thank you, and I'll stand for any questions.
Thank you. Questions? Representative Healy.
Yes, thank you, Madam Chairman. Mr. Kleinworth, can you elaborate on the 2 and 5 improper payments? That's a large number. Can you tell me more about that?
Mr. Kleinworth.
Madam Co-Chair and Representative Healy, thank you for that question. This is information from the Center for Medicare and Medicaid Services. This did not come from the Idaho Department of Health and Welfare. The latest audit that they did was in 2019, where 39% of the payments that were issued to providers were improper. This is either from providers that were either payments made for beneficiaries that weren't actually eligible for the program, or billing errors where they were billed for services that weren't actually provided, or the services didn't match the code completely.
Follow up?
Yes, thank you, Madam Chairman. Were those costs brought back, I guess? If they know that they're out there, wouldn't those be brought, like, recaptured? Thank you.
Mr. Kleinworth.
Madam Co-Chair, Representative Healy, thank you for that question. We don't have enough data on that to truly know how much that money was actually brought back.
Right.
Another follow-up?
Yes, thank you. One more. Mr. Kleinworth, the RX costs, can you elaborate on that more? When I look at prescriptions, oftentimes those are what are preventing patients from going into the hospitals. You know, you look at hypertension medications, that's what prevent patients from having strokes, high cholesterol medications, et cetera. What would you suggest would be an alternative to prescriptions?
Mr. Kleinworth.
Madam Co-Chair, Representative Healy, I'm not necessarily recommending an alternative to prescriptions. I believe that that point wasn't entirely accurate. So the issue here is that the argument is that the prescription drug benefit is the fastest growing component of the Medicaid budget. But it's driven by use. It's not driven by the cost of the drugs themselves. 1 in 5 prescriptions are for mental health drugs or psychotropic drugs. But the problem is that we're not talking about people who are needing hypertension drugs or people who need diabetic medications. We're talking about people who are maybe needing to use the system for other things.
Yes, sorry, one last one. So if I'm understanding this correctly, an antidepressant so antidepressants, in my opinion, would cost less than a psychotropic hospital admission, which would be the point of them. But you're saying if we don't pay for those, we'd save money?
Mr. Kleinworth.
Madam Chair, Madam Co-Chair, Representative Healy, that's not what I'm saying. What I'm saying is that we have a problem in this country where people are dependent on the government for their drugs, and a better system would be to find a way for these people to not have to use these drugs.
Senator Zeiderfeld.
Thank you, Madam Chair and Mr. Kleinworth. And you only have a short time, but I was wanting you to go a little bit deeper on the MCOs don't promote budget predictability. Can you maybe explain that in just that short time a little bit deeper for me?
Mr. Kleinworth.
Madam Co-Chair, Senator Zeiderveld, that particular graph, what I was showing was a regression analysis of the budget growth for all 50 states. And so what you see is that in a short period of time, you could predict a budget on a linear trend within a reasonable margin of error. What you find is that for the majority of the states, regardless of the management system, the management system did not improve budget predictability.
Representative Tanner, you've got 30 seconds.
All right, thank you, Madam Chair. Mr. Kleinworth, you had mentioned for 9 states that were kind of forced back, or a news article that forced them to stop us from the unwinding process. Can you just elaborate a little bit more on that?
Yes.
Kleinworth.
Madam Co-Chair and Representative Tanner, in the 10 seconds I have left, I'll just mention that this was for procedural redeterminations. This is about 44% of the people who were disenrolled. We need to investigate more as to why that was stopped.
Okay. Wow, you did really good. Right on time. Thank you.
Thank you.
Okay, our next presenter is...
Madam Chair, if I may make a correction,
Yes.
I believe the presenter said that Idaho Health and Welfare is not doing the redetermination. They have done through that process and have 103,000 people that are no longer qualified. So the Department of Health and Welfare is doing the redetermination, has not been stopped by CMS, and is doing a good job, I believe, of going through that redetermination process.
Thank you. Okay, our next presenter is the Idaho State Dental Association. We have 2 presenters listed. Dr. Keller, I believe you are up. Is that correct? Welcome to our task force, and the time is yours.
Thank you very much.
That's a really...
Your mic's on.
I think it flipped off. It was on. So we might have to have you move to one of the... Oh, hang on.
Check the plug underneath.
You've got to make sure that microphone goes up, or have him sit down, because he's quite tall, and it's going to be very temperamental. There you go. Welcome to committee. Please identify yourself for the record.
Thank you, Madam Co-Chair and Medicaid Task Force Committee. My name is Kim Keller. I'm a dentist from Nampa and the immediate past president of the Idaho State Dental Association. I was the dental director for DentaQuest, the previous MCO that had the dental contract in Idaho. I'm also currently employed by the state as a consultant with the Idaho Department of Health and Welfare in the oral health program. Dentists are in a unique position to be able to provide public comment on Medicaid managed care, as Medicaid in Idaho has been run by a managed care contract for dentists for over a decade. I'm going to share our experience with that first, then share some suggestions or solutions at the end. I can say that from the healthcare provider's point of view, specifically dentists, it doesn't look like managed care to us in any way. For us, it simply presents itself as another insurance company with complicated rules and more hoops to jump through. We are accustomed to the inconvenience of third-party payers, but not ones with fees that reimburse far below the actual cost of doing business. In short, for us to participate in managed care, it is simply the worst insurance business decision that you could possibly make for your practice. The idea behind hiring an MCO to interface with the healthcare providers is that the state can come up with a budget, define the population to receive that service money, but then pay an insurance company a cut of the budget to take care of the population. The irony for us in dentistry is that the state is guaranteeing a non-healthcare provider a profitable contract while expecting the providers to sign up and see the patients at a financial loss. And many of our providers do sign up. Most of them, like myself, stay signed on to help a few friends or longtime patients who may be struggling with disabilities, and they've been on and off Medicaid through the years. But our internal surveys are proving that the trend that many of these dentists, we're seeing many of our dentists are no longer accepting new patients, which means we may see lots of people signed up, but not many patients being seen. This results in our members reporting that they are seeing less and less Medicaid patients every year. This will affect access to care, not because of lack of providers, but because of lack of funding. Our association has worked very hard through the years to develop relationships with the representatives at the Department of Health and Welfare and with the MCOs that service our contracts. And we feel that all parties have the patient's best interest as their #1 priority. I consider all of these people colleagues in the pursuit of the best care for our patients. However, the managed care structure currently leaves the dentists completely out of the loop when the state contracts with an MCO. There are no dentists on any authoritative committees or governing bodies when these deals are made. Yet, they are the ones being asked to provide the care at a financial burden to their practices. Likewise, there are no dentists on any governing or oversight committees after the deal has been made. We have very qualified and experienced providers who, with access to information and some kind of an authoritative vote, could help move these state resources to better manage the needs of our dental patients. I received an email of gratitude 2 weeks ago from the sister of a 60-year-old schizophrenic patient who needed his teeth extracted in preparation for dentures. My partner and I have taken care of this patient the best we can for many years. The email was sent to 9 people, 3 managed care organization employees, 1 Department of Health and Welfare employee, 4 dentists, and the executive director of the Idaho Oral Health Alliance. All were very compassionate and worked hard to take care of this patient, but that is too many parties getting in the way of a provider-patient relationship. This increases the cost in an already small budget assigned to dentistry. Imagine the cost increase had adult dental care been cut from the budget this year, as had been suggested earlier in newspaper reports. This patient, who faces many health challenges, would have had to go to the emergency department each time a tooth got infected, and the state Medicaid budget would have been hit with high-cost visits over and over, with nobody in the ED trained to do only what a dentist or an oral surgeon can do. In summary, managed care, in our experience, has, #1, kept reimbursement so low that it now threatens access to care. #2, it has incentivized insurance companies while de-incentivizing providers. #3, it increased the complexity of care for those who are the most in need. And #4, has excluded the providers from the conversation on how to best manage the taxpayer resources while simultaneously financially penalizing them when they do participate. I'd like to just give a couple of thoughts here. I appreciated Mr. Lullenquist's inclusion of incentives to keep the providers involved. We totally understand his point of view of sending money out to insurance companies versus the providers instead. I would suggest things that we look at, such as maybe paying providers directly in some sort of fashion through a PMPM payment directly to the providers. That we can also look at areas of the state that have greater needs and shift costs or reimbursements to providers in those areas. Right now, it's a very blanket approach with a very low fee schedule that everybody takes into account, which means some areas of the state get some service and others don't because the fees are so low. My time is up, so I'm getting flustered, so I'll pause.
Well,
For
would you
questions.
take some questions?
Yes, absolutely.
Okay. Questions? Senator Cook.
Thank you, Co-Chair. Thank you, Dr. Keller, for your comments. I appreciate that. In your opinion, have we lost dentists due to the MCO?
Mr. Keller.
Madam Co-Chair, Senator Cook. We have been doing this for a long time. We always have dentists coming in and out. You won't see the number of dentists signed up lessening because they still feel committed to help people, but you'll see the number of patients that they see dwindling quickly. The high cost now that we're seeing in staffing and in supplies and all the other things we're dealing with means that there are dentists who have taken it as a subsidy, let's call it, not a way to earn money, but as a subsidy to help the public. Now they're starting to drop off in favor of other insurance companies.
Follow-up?
Follow-up.
So are we seeing more of these patients than Medicaid patients because they can't get access to the dentist? Are we seeing them showing up in the emergency center, and is there any idea of a cost on that?
Mr. Keller.
Ms. Co-Chair Van Orden, Senator Cook. We only have data, and you have it in a packet that the ISD letter sent to you in reference to the state of Oregon, where they showed the dramatic increase in costs. We felt it. I can't give you exact numbers, but when we cut adult care several years ago, we felt a big change in the ED's response. And you can ask them to verify that they saw a lot more increase in costs. It's just more expensive to take care of a patient in ED than in a dental office to remove a tooth.
Thank you.
Senator Wintrow.
Thank you, Madam Chair, and Dr. Keller. Let's go back to your solution, since at the end you are getting a little flustered.
Yes,
because of time
sorry
running
about
out.
that.
But I really appreciated some of those thoughts about incentivizing, instead of doing a blanket approach, incentivizing areas where there is higher need. I'm most concerned about some of those other solutions. I want to give you a little time there.
Thank you.
Mr. Keller.
Co-Chair and Senator Wintrow. One thing that I've always wondered about is why we don't take more of an effort to do a more public and private partnership where even the state can be involved in monitoring things. We just heard from Mr. Kleinworth that sometimes there may be mistakes in billing or maybe incorrect billing, but why can't we do a public and private partnership where we pay the dentists and the assistants a fair competitive salary and take care of as many patients as we can? When you throw a third party into that and have them start getting in the middle of it, then you find that you can't pay anybody the right rates within your office. But maybe if we had this budget set aside to work with a private-public combination of services, we could treat more patients that way without these concerns of misutilizing the funds.
Follow-up.
Thank you, Madam Chair and Dr. Keller. I really appreciate that. And so I think what you're saying is kind of going back to a similar fee-for-service, however, working more closely with the department maybe, that would require maybe appropriate and qualified staff in each area to help, I guess, partner with, they would be kind of the managed care organizer, right? The Medicaid staff, if we had the appropriate, qualified, and robust staff to do that. Do you think?
Mm-hmm.
Mr. Keller.
Senator Van Orden, Senator Co-Chair Van Orden, Senator Wintrow. Yes, and I think it goes back to one of the points that I've tried to make and that we make over and over again is the dentist and the dental community and the ISDA are always completely left out of every conversation of how to take care of. We get token responses, put on token committees, but nobody is ever has to listen to what our opinion is. They may, but they're going to do what they're going to do because it's the MCO or the Department of Health and Welfare. Again, I'm not blaming people. I'm just saying that there are limits the way that it's working right now. But if we brought the dentists in and had a more robust discussion of where we think the needs are, the problems that we're seeing, we could contribute a lot more to how this money is spent versus just handing it off to an insurance company and say, do your best. We want to keep our costs right here.
Another question, follow-up?
Thank you, Co-Chair and Dr. Keller. I think just for a quick comment, I think what you're echoing is some of the OPE recommendations in their reports about rate setting is that they should be transparent and that robust stakeholder involvement. And I have found in my experience with non-emergency medical transportation, if you go directly to the providers in the trenches working every day, they'll tell you the shortfalls. And I think I appreciate you coming today and documenting that for the record, that we need to listen to people in the trenches doing the work, hear the shortfalls, and try to address those problems. So thank you.
Thank you, Senator Montreux. Thank you,
Any other
Co-Chairman.
questions? Representative Roberts, I can't see your mic, so make sure you flip it up when you turn it on. Okay. Okay. Thank you. Oh,
Just a quick statement, Madam Chair. And what I'm hearing from you is the dentist would like to have a seat at the table when we put together whatever decision that we decide that you want a seat at the table, correct?
Senator,
Keller.
Co-Chair, Senator, absolutely. And we have a lot to offer, and we are good sports and good players at the table.
all right. Thank you. We're going to take a second and get our microphone working here.
Testing 1, 2. How's that? A little better?
Will it go straight up for our tall presenters? Thank you. Thank you very much for helping us with that on such short notice. Okay, our next presenter is Aaron Houston, Community Health Center Network of Idaho. Okay. You'll need to flip that mic on. I think he turned it off. There you go. Thank you. Please identify yourself for the committee.
Good morning. My name is Aaron Houston. I am the CEO of Family Health Services and the Vice President of the Community Health Center Network of Idaho. Madam Chair and Committee, thank you so much for your time this morning. We are community health centers. We are throughout Idaho. We are nonprofit organizations. We don't turn anybody away for their inability to pay. We have about 22% of our patients are self-pay, meaning they don't have a payer, and another nearly 40% are Medicaid payers. We have a small group of Medicare and then some insurance. And on the insurance side, I will tell you that a lot of those are like a catastrophic insurance. And so even though they have a payer, they don't really have a good payer for managing kind of day-to-day illnesses and things like that. There's 15 organizations with 200 clinic sites. We have about 217,000 patients. And like I said, most of our clinics are in rural Idaho. That is just a quick map of reference of where everybody is and who we are. We have the Community Health Center Network of Idaho is a Medicaid VCO partner, and we have nearly 50,000 members and are the second largest in the state with the VCO. We have felt strongly that the VCO has been an effective project that we have collaborated on, been a partner on, and even though it's kind of gotten pushed back over a couple of years, preliminary results from Medicaid have indicated that we have saved approximately $4.6 million so far through that. By contrast, an MCO, like it's kind of been discussed, there's going to be some of the cost is going to go towards the managed contracting agency, the insurance company. So if you go with maybe a 15% administrative cost, you're talking about a cost of $12 million a year. So we would like to see the VCO have a little bit more time to see if that is actually going to continue to save money along with Medicaid redetermination. Timing seems to be of issue as to whether or not the VCO can have more significant savings. We've also invested quite a bit into the program that we hope to have additional savings. For example, having a diabetes education program that we didn't have before, starting to work on pre-diabetes as opposed to waiting for a patient to have diabetes and take care of them. Those are all things that we feel like the VCO is geared towards helping with through the extra payment by keeping folks healthy. So in summary, from the community health centers, we believe that remaining a VCO ensures the Idaho health centers continue to fulfill our goals, its cost savings, and its effective healthcare delivery to our communities. I'm early. Wow, I talked too fast. I apologize. So, Madam Chair, open to questions.
Okay, thank you. Committee, any questions? Senator Wintrow.
Thank you, Madam Co-Chair. And just quickly, thanks for your quick presentation, but maybe you can just expand upon a little bit the community health center's role with VCOs and how some of that process has worked and where you're seeing some of those savings and how you're reinvesting, I think, back into the system with those savings, correct?
Mr. Houston.
Madam Co-Chair, Senator. Yeah, so we've really put a lot of effort and time and energy into preventative health. Through the VCO, it gave some pretty specific goals for where Medicaid wanted us to focus time and energy on for those patients. So A1C control, well child checks, decreasing hospital readmission rate. So we've hired care managers and care coordinators to reach out. We've worked closer with the hospitals on partnerships that as somebody is discharged from the hospital, that they get an appointment, that they are not kind of lost, that we do medication reconciliation, that they get in for their primary care and are taken care of that way. There's still work to be done. Family Health Services earlier this year just was accredited a diabetes education program. And so we are just now getting that off the ground and going. We feel like those kinds of investments back into our programs to help the self-pay patients and the Medicaid patients to keep them healthy, to keep them from getting diabetes and then ending up in the hospital system for a long-term stay. We also do dental and behavioral health, and it's all about prevention. It's all about taking care of the patient in the clinic as opposed to going to the ER for a dental or inpatient for something mental illness or something like that.
Follow up?
Thank you real quickly. Thank you, Madam Chair, and thank you so much. So it sounds like what really struck me when you were talking there is that you're reinvesting in folks who are basically creating networks with patients. So I think about my 85-year-old dad before he died. He was using the emergency room all the time until we got a kind of an in-home nursing model to prevent some things so he wouldn't go to the hospital all the time. So it sounds like you're building relationships with patients, trying to identify upriver solutions to decrease the cost downriver. Is that right?
Mr. Houston.
Thank you, Madam Chair. Senator, yes, that is what we are trying to do. We focus both on really the self-pay patients and the Medicaid patient because in a lot of instances, somebody that doesn't have insurance and is self-pay will become a Medicaid eligible patient. And now if they haven't had access, they're kind of a mess and a lot more expensive. So if we can provide that care, invest it back through Medicaid into the programs, through the VCO model with some incentives to really put those things in place, we really will have a healthier Idaho, which means more kids going to school, which means more workforce, more people paying taxes. So.
Senator Cook.
Thank you, Co-Chair. Thank you, Mr. Houston, for your time today. A comment and then a question. The comment was that a lot of the things that you were saying about preventative health, taking care of the patient before they get super sick. That sounded a lot like what Mr. Lindquist was talking about today in the MCO, the same kind of thing. But the difference is with the VCO is we don't have a 15% admin cost. And so I was encouraged by hearing what you said with the preventative health. My question is you said you also do behavioral health. My understanding is behavioral health is one of those MCOs that we have in the state. Could you tell us how things are going with that if you're prepared to state something there?
Mr. Houston.
Co-chair, Senator. Yeah, just real briefly, the downside on the behavioral health with the managed care program is we see a lot of things like prior authorizations, number of appointments that are allowed, things like that really do tend to restrict access. We have a lot of requirements that actually take patient time away from an appointment for really for just taking care of the kind of paperwork. So we now block up to 2 hours a week per counselor that used to be patient time. Because of the MCO under behavioral health insurance company requirements, we now don't see 2 more patients a week per counselor that we would have prior to the MCO. So those are some of the things that we see that kind of affect access by pre-authorizations, limiting number of appointments, additional paperwork.
Really good
Follow-up?
follow-up.
Sure.
Thank you. So do you foresee that an MCO causes more paperwork, more admin cost to you as cost to providers to go under this?
Mr. Houston.
Madam Chair, Senator, there's that significant potential that one of the ways that they will make sure that they hit budget is by limiting access by number of providers, adding administrative burden like doing things, pre-authorization, denying claims, requiring more administrative burden so that we don't have the ability to see more patients. I do think limiting access is a real strategy of an MCO if the wrong insurance company is selected to make sure that they hit budget and they keep their profit margin.
Thank you.
Thank you. Health Plans of America. The Medicaid Health Plans of America, or MHPA for short, is the association solely focused on the Medicare industry. Both for advocacy and research, MHPA supports innovative policy solutions that enhance the delivery of comprehensive, cost-effective, and quality health care for Medicaid enrollees. We work on behalf of our 140-plus member managed care organizations that serve more than 50 million Medicaid enrollees in 40 states, soon to be 41, DC and Puerto Rico. Our members include both for-profit and nonprofit, national and regional, as well as single state health plans that compete in the Medicaid market. Thank you for allowing me today to talk briefly about the value of Medicaid managed care. So to start, as of 2021, nearly 3/4 of all Medicaid beneficiaries nationally were in comprehensive managed care. At its core, Medicaid managed care exemplifies the public-private partnership that, through competition inherent to the bidding process, drives innovation and works to ensure that the state and federal dollars invested in Idaho's Medicaid program are used as effectively and efficiently as possible. Medicaid MCOs are partners in the delivery of care and services, whether working with their partner states, the federal government, providers, community organizations, or Medicaid beneficiaries. Cost containment guardrails are built into the managed care delivery system that provide budget predictability and stability that is not found in fee-for-service. Capitation rates for MCOs are required to be actuarially sound and approved by CMS, and the 2 most used mechanisms for implementing mandatory managed care, Section 1915B and 1115 waivers, require that expenditures are lower or equal to the cost as if the waivers were not in place. Other financial benefits for states contracting with MCOs include aligned financial incentives, accountability, and limited financial risk. The state can also include unique requirements in their contracts to ensure that the services provided by MCOs are high value and high quality, such as value-based payment arrangements. MCOs are also accountable to their state partners through contracts that include enhanced quality performance metrics and data analytics. The standards that MCOs are required to meet do not apply to other delivery systems. MCOs are aware that these requirements may increase provider burden, and in recent years, CMS has put new regulations in place to try to alleviate this provider burdens, and MCOs also routinely look at ways to lessen provider burden as well. Idaho is in the unique position to understand this going in and work with the providers and MCOs on how to best make sure that the standards are being met while also ensuring provider burden is minimized. In addition to being accountable both financially and qualitatively, MCOs strive to provide innovative solutions that improve the lives of their enrollees. Medicaid MCOs are uniquely positioned to provide holistic care to Idahoans through their care management and coordination operations. Care management optimizes family and caregiver engagement, including ensuring that communications with family and caregivers are transparent, clear, consistent, culturally appropriate, and take into consideration the issue of health literacy. Support provided by a coordination team and consistent care management can help a child or a family navigate multiple healthcare systems and providers to ensure timely and appropriate care. MCOs collaborate with local partners, such as community-based organizations, to better understand the needs of those they serve and are also embedded within their communities. To provide even more value, MCOs will often provide value-added benefits in addition to what is covered under the Medicaid state plan. Examples of these value-added services that MCOs provide their members, which is as part of their administrative costs, so the 15%, this is included in that. These include dental services beyond what is included in the Medicaid state plan, additional vision services, programs for newborns and mothers, virtual urgent care, 24-hour nurse lines, services that address social determinants of health, gym memberships, funding to help members successfully obtain their GED, and incentives for completing wellness activities. In closing, as you continue your discussions around the possibility of bringing comprehensive managed care to Idaho, I cannot stress the importance of a continued robust stakeholder process, which, as witnessed here today, you already understand the importance of. While any transition and programmatic changes have risks, engaging stakeholders and working together is the key to ensuring successful implementation. Once again, I would like to thank you for the opportunity to provide testimony, and I'm more than happy to take questions at this time.
Wow, right on time. Are there questions of the committee? Wow. Oh, Representative Tanner.
You sounded disappointed, Madam Chair. Okay. So, yes, that was extremely fast, and I appreciate all the information you provided in there. Could you maybe speak a little bit more to, you said the MCOs would provide more than what they're required to do. I haven't actually seen that yet throughout all the MCOs that I've kind of looked at. I think they streamlined the process a little bit better, but I haven't seen where any of them have actually added additional services for free, in a sense, within their 15% back to the community.
Ms. Myers.
Madam Co-Chair, Representative Tanner. So the list that I hear is not a comprehensive list. Part of it came from the state of Texas. The additional dental services has been provided by a health plan in New Hampshire. So as you go to look, and if you look on the state's websites themselves, you can find, and I'm more than happy to provide this information to you afterwards, a list of, not only what they cover, but what they cover in addition as value-added services. And it usually is unique. You can kind of see it right there. So I'm more than happy to provide that information afterwards to you so you can kind of see what the states offer in addition to what is required in the contract.
Follow-up?
No, thank you. Thank you.
Thank you. Senator Wintrow.
Thank you, Madam Co-Chair and Ms. Myers. Thanks for your presentation. Quickly, how might you respond to the previous presenter, Mr. Houston, and some of his points that he made about MCOs?
Mrs. Myers.
Madam Co-Chair, Senator Wintrow, can you be more specific?
Senator Wintrow.
Sorry. I think Mr. Houston was talking about some of the drawbacks of some of the administrative burdens on providers that MCOs seem to place. And he's basically indicating that 2 less patients are going to be seen now because he has to devote staff to administrative time to cover the requirements from the NCO.
Ms. Myers.
Madam Co-Chair, Senator Wintrow, I understand where he is coming from. A lot of, some of the burden that we have to put in place is because of requirements on the MCOs, kind of like a top-down approach. The federal government has their requirements that flow down to the states, so the states then have to put out the contract, so then we have to then push that onto the provider. But as I mentioned before, we're always looking for ways to streamline, so to make that less of a burden, because our MCOs do not want to have, the providers doing paperwork all day. That is not our goal. We want providers to provide care for our beneficiaries so that they can become better, so that they can go into the workforce, so that then they can graduate from the Medicaid program. So I do understand where he's coming from. Our MCOs do work to try to figure out ways to provide, to lessen that burden, and are, at the ready, especially as this process goes forward, to work with its state partners and the providers to try to make it as streamlined as possible.
Vice Chair.
Thank you, Madam Chair. And just a quick question. You said something about 15%. Is that the standard on MCOs, or can it be 5% or 2%, or is that a standard in most MCO contracts?
Ms. Myers.
Co-Chair Van Orden, Co-Chair Vanderwood. So the 15% comes to an 85% medical loss ratio. This is the percentage that you will find in federal regulation that they determined based on what would be kind of like the administrative cost needs for a plan to be able to run, essentially. Now, that's the floor. That I will admit that is the floor. When determining an MLR, that can obviously be higher, but you want to take into account what are the needs of the MCOs to be able to run their plan and run their plan effectively and efficiently. And I would suggest, when determining that, to work very closely with your Medicaid director, who has a lot of experience with this, and then also with the MCOs as well, because they can kind of provide you that input.
Follow up? Okay. Seeing no more questions, thank you. Thank you for being here with us today.
Thank you so much for having me.
Mm-hmm. Okay, committee. Next, we have Stephanie Hartruff. Is she virtual? Okay. We'll move past her to Kelly McGrath, and I believe I saw him online, correct? Welcome to committee, Mr. McGrath. Can you hear us okay?
Yes, I can. Can you hear me okay?
You'll need to speak up a little more.
Okay. Usually I can.
Could you identify yourself for the record, and then the time is yours.
Okay.
Proceed.
Co-chairs and members of the committee, my name is Dr. Kelly McGrath. I'm a rural family medicine physician in Orofino, Idaho, where I've had the privilege to serve for the last 30 years. Regionally, I am the chairman of the quality committee of a clinically integrated network that participates in Medicaid VCO. And on the state level, I am the co-chair of the Payer Provider Work Group, whose mission has been to advance value-based payment models in Idaho with all payers, working collaboratively with providers and payers to deliver the best and most efficient care to Idaho citizens. These roles give me a direct knowledge of what it takes to improve the quality of care at the lowest possible cost for Idaho Medicaid patients. This work is often nuanced and requires an intimate local knowledge of our communities, their challenges, and the resources that are available to do this work. This is what we do in the Medicaid VCOs. A managed care organization for Medicaid cannot provide this level of precision that's necessary to be successful and drive these outcomes. In my role as a rural physician, I've seen the health impacts to individuals and perhaps more importantly to the economic health of my community as a whole as patients move through the Medicaid program. Often Medicaid patients intersect the program at the highest risk times of their lives, whether that be pregnancy, childhood, growing up in an impoverished family, critical illness, or in mental health crisis. Quality of care that they receive during these times is really what leverages the long-term impact of on their health and actually on the total healthcare costs to Idaho taxpayers over time. It's not just during the period of time that you're on Medicaid, but it casts a long shadow ahead. While this may be hard to see at the state level, it's really quite clear when I move about in our small rural community where I can see those impacts directly. Early intervention in illness and the provision of quality preventive care upstream reduces those downstream healthcare costs that are substantial. We often know the individual stories of what this looks like, and it cannot be achieved by remote managers of an MCO who are intent on maximizing their profits through the creation of administrative burdens and blanket rationing of care. Also in rural communities, access to specialty care is one of our biggest challenges for our Medicaid patients. Adding a layer of bureaucracy with the Medicaid MCO can only worsen this kind of access. This in turn will negatively impact outcomes and create increased costs from delayed or rationed specialty care. Recently, I saw a woman who's been a patient of mine for 30 years. I met her initially as a troubled teen growing up in a family that was saddled with poverty, mental illness, substance abuse, and medical illness that was significant. And we had a great moment where we shared in the joy that she now has a great job. She's a vital member of our community and really a big contributor to the well-being of our community. She credits much of that outcome really to the care that she received in our patient-centered medical home that helped her to navigate some of the challenges she had. Many of those services that she received really are subsidized by our local system, which aren't reimbursed, but they actually are implemented to create that kind of care value that we need for these outcomes. MCOs really can't incentivize this kind of care and really create this innovation. It really comes down to where those incentives are aligned. For the MCO, it almost by definition has to be with their stockholders to maximize profits through implementing barriers to care to be a carve-out from the care for Idahoans. For the VCOs and providers locally, it's much different. We have shared risk with Medicaid using local knowledge to improve the lives of Idahoans while reducing both short and long-term costs. MCOs kick that cost can down the road, but it doesn't leverage the long-term outcomes that we need for Idaho. The VCOs have made great gains already despite launching during the pandemic. They need to be allowed to grow that opportunity for Idaho. Thank you for your time.
Thank you, Dr. McGrath. Questions of the committee? Senator Wintrow.
Sorry, Madam Chair, but just real quickly, Dr. McGrath, your audio for me was a little hard to hear, so I just want to be really clear. Are you advocating continued use of the value-based care model right now to see where it goes and building upon that versus shifting to a managed care organization?
Mr. McGrath, please answer.
Thank you, Chair. I'm sorry about the audio. I guess it wouldn't be a virtual thing if there wasn't something went wrong. Yes, I am advocating for the VCOs. I mean, how we've been doing care for all these years isn't giving us the outcomes we need for the whole country. We need to shift to value-based care, and there's risk to us as providers to do that, but it's going to drive the innovation that we need. And so is exactly, I mean, we just are getting started with this. We need to see it through.
Any more follow-up? Co-Chair Vandewater.
Thank you, Madam Chair. And Mr. McGrath, where's the accountability and oversight in the value care system that we now have?
Mr. McGrath.
Chair, I think the accountability is really that there's downside risk, right? I mean, providers and the VCOs have skin in the game. We're challenged. If we're not successful, we've got downside risk. And that's where we work as a partner with Medicaid. And actually, we're doing it with other payers as well. It's that model of where we engage in the risk. And that's what will drive what we need.
Follow-up.
Thank you, Madam Chair and Mr. McGrath. I think we all understand that value-based care is an important element in the care for these individuals. So why can't value-based care also be part of a managed care program? I don't believe that value-based care is exclusive to what we're doing now. I believe that can be, I think Utah did some of that in their managed care program. So why can't that be done with a managed care program?
Mr. McGrath.
Thank you, Madam Co-Chair. Well, I suppose it could be. And yeah, I would agree with that, although really where the value is created is by having those that are delivering the care have that risk and knowing the resources locally. I think you can call that value-based care, but you've introduced another level of management in between, and I don't see how that delivers more efficiency to the care. A lot of the things that we do locally is addressing social determinants to deliver better outcomes, and I think we can only do that by having a more direct line of sight on the care. I understand the question. I don't know that they would be prevented from using that tool. I just don't see that it would be as effective. Thank you.
Senator Cook, did you have a question?
Yeah, I do. Thank you. I guess, thank you, Mr. McGrath, for your time. Your last statement there, you said you didn't believe it would be, you thought it would be less effective. Why is that? Why would it be less effective versus an administration versus the providers? Because I think a VCO puts all the weight and the risk on the providers, whereas the MCO, it really puts it on the administrator. But where do you stand on that? What are your thoughts?
Mr. McGrath.
Thank you, Madam Co-Chair. Well, I think this is a really important point that you're on, is that it's administrative, maybe administration that may be even out of state, and they're using a solution that may not be local, where the providers who have skin in the game know what the resources are. Something that works in New Jersey is not going to necessarily work in Orofino, Idaho, and there's some nuance to it, and that's really where the providers know that. That's where I believe, and I've actually already seen that value created.
All right. Thank you, Mr. McGrath, for being with us today. We appreciate you getting online, taking the time. Okay. All right, committee. Next is Brian Whitlock from Idaho Hospital Association. Welcome to the committee.
co-chairs and members of the task force, Brian Whitlock with the Idaho Hospital Association. Co-chair Vanderwatt, at the outset, you said you're looking for really good ideas. And so I thought I would just take a minute and share with you what your predecessors decided was a really good idea.
I hope your good idea jives with mine.
I'm working on it. I'm going to get you there. I wanted to share the good idea that your predecessors came up with in 2011. So I've included some handouts. Hopefully you have those in your packet. But while you've had a brief overview of how VCOs were set up, I thought it would be actually good for you to read the language of the enacting legislation for managed care in Idaho. So you have in your packet House Bill 260 from the 2011 session, which gave the green light for Medicaid managed care in Idaho. You also have in your packet House Bill 351 from the 2020 session, which directed the department to move from a fee-for-service environment into, quote, paying for services based on their value in terms of measurable healthcare quality and positive impacts to participant health. I'm seeing some questions. Is this not in your packet?
Oh, committee, it is part of the one you've got a clip on that says healthcare access and affordability.
Okay. So those two pieces of legislation I think are worth reviewing so that you understand how we arrived at where we are today with value care organizations. By forming VCOs around the state, providers, as you've heard, were held accountable for cost containment, and they took on financial risk for health outcomes of some of our most vulnerable populations. The foundation for all of this is the Healthy Connections Value Care Program, which again was spelled out in House Bill 260 from the 2011 session. Despite being in a global pandemic, VCOs launched on January 1st, 2022, and we still don't have the final data on that first performance year of 2022. That should come later this month or next month. One thing we do know is that when the contracts were signed for the second performance year, which we are currently in the middle of because those run on a calendar year basis, the one thing that we know for sure is that the department decreased the per member per month target costs for VCOs in those contracts. So I think that speaks volumes for the opportunity that VCOs have to not only save money, but also to improve health outcomes because those are all spelled out in the VCO contracts. VCOs, as you've seen today, come in all shapes and sizes, but there are some things that they all have in common. They are all provider-led organizations. The providers are willing to be held accountable for the care of those patients. They're willing to accept risk on the health outcomes of their patients. And this shouldn't be lost on you. They were willing to invest tens of millions of their own money in the infrastructure needed to position their VCOs to help control costs and improve health outcomes. There was no appropriation from the state to do that. There was no medical loss ratio built into the contracts, unlike MCO models. And now today we have 97% of Medicaid beneficiaries in Idaho enrolled in the Healthy Connections Value Care Program. I don't know of any other way that you maintain that kind of extensive network and the coverage that we see other than through a provider-led VCO structure. In my opinion, turning this over to an insurance company to run would just shrink the provider network around the state. I've included some recent red flags also in your packet as well that have providers concerned, and this is just from the last 2 weeks. In your packet, you have a report from the Office of Inspector General for Health and Human Services. Title of the report, High Rates of Prior Authorization Denials by Some Plans and Limited State Oversight Raise Concerns About Access to Care in Medicaid Managed Care. An OIG report just out in July. Next in your packet, you've got a large health insurance company that's being sued in a class action lawsuit over automated patient claims denials. They looked at a 2-month
Mr. Whitlock,
period.
I'm gonna give you extra time too.
Okay.
But committee, these are all online, correct? Grace, it was on the email that you received.
Okay.
Keep going.
And I'm just trying to hit the high points. They're there for your review
You're fine.
after
Keep
the
going.
meeting. So, again, this is a class action lawsuit because in a 2-month period, this insurance company denied over 300,000 claims, and the average denial time to review the claims and deny them was 1.2 seconds per claim. They were using artificial intelligence to automatically deny 300,000 claims over a 2-month period. And then finally, online in your packet, you'll have something from the U.S. Department of Labor, which sued a large health insurance company's third-party administrator for denying claims, including emergency services in the hospital. And so those are just red flags that have come up in the last 2 weeks that I hope that you'll dig into and try to understand why providers across the state are concerned about moving from the current system that they've invested millions of dollars in, when you've already heard, at least in your last meeting, that the cost savings of managed care are inconclusive, and we have a system in place right now that we haven't yet proved or have all the data to prove how it can save money and improve health outcomes. So my request, in concert with HCR 9, which formed this committee and directed you to come up with a report and recommendations, if any, to the legislature in January of 2024, is to allow VCOs to continue to work. Let that play out. At the same time, you have other managed care contracts in place. We've just announced that there's a new provider or a new insurance company leading the behavioral health plan in Idaho that now includes both outpatient and inpatient. It's going to take about 37 weeks of a ramp-up period before they're up and fully running. So you don't have the data yet to say, yes, we know that MCOs work in behavioral health space. So let the VCOs play out, let the managed care for behavioral health play out, and then let's weigh the options of what we need to do. I don't have time. I also included in your packet a public opinion poll survey that was done last month. It looks at the issues of access and affordability and what your constituents have on their minds when it comes to the cost of health care as well as access to health care. With that, Madam Co-Chair, I'd be happy to stand for any questions.
Senator Cook.
Thank you, Madam Co-Chair. Thank you, Mr. Whitlock. We heard earlier from, I think, Dr. Keller, that they really wanted some dentists at the table when they did the MCO. Did we have providers at the table when we came up with the VCO? This is before my time, so thank you.
Madam Co-Chair.
Mr. Whitlock.
Senator Cook, absolutely. Frankly, based on House Bill 260 that was passed in 2011, we saw this coming. And at the time, the department was adamant that this be a provider-led managed care organization, not giving a 15% administrative cost right off the top and out of the provider's pockets to somebody else to manage the system. And so going back to Dick Armstrong at the Department of Health and Welfare, when he was the director, as he sought ways to implement House Bill 211, he came up with this idea for value-based reimbursements. They looked across the country and potato, they thought, do we call it an MCO? Do we call it an ACO? Do we call it a VCO? What do we call it? So we went back and forth on what we even named this thing. We were almost down the road of an ACO, and then they said, no, rather than being accountable, we want to provide value both to the Idaho taxpayers as well as the Medicaid recipients. So we settled on value care organizations. During the pandemic, October of 2022, we invited all of the providers to come and hold a conference. We held it with Ms. Sharon's predecessor, Matt Wimmer. We got everybody in the room, and we said, okay, we've got House Bill 351, which says we're moving forward on this. How do we structure it? And it took the department some time to pull together the data. But again, bringing everybody to the table was key in order to get support for House Bill 351 in 2020, and then the implementation of that, which ultimately resulted in the value care organizations. And I think the VCOs still have a seat at the table, and they work very closely with the department. Right now, they're in the process of negotiating that third performance year contract, what that PM will look like. So I think there's good interaction and good seats at the table between the VCOs and with the department. Now, again, I think it's important to note those VCOs all look different. You heard from the community health centers earlier this morning. That is not a hospital-based value care organization. There's a children's clinic over in Pocatello that has a VCO. That is not a hospital-based. What we tried to do was figure out how do you reach the most people and do it in a way that you can contain costs and improve outcomes. And again, we brought everybody to the table and worked with the department to come up with the contracts that have been signed by 11 organizations. And as you've seen, there have already been some cost savings that were generated from that first performance year for some of the VCOs.
Co-chair.
Thank you, Madam Chair. And Brian, I didn't quite grasp your really good idea yet, but my question is, in this last session, the department asked for auditors or to go over all the claims from the VCOs. There was a request for somewhere between 10 to 25 actuaries to basically go over all the claims from the VCOs. Why would they do that, and what's the value? I mean, I got told it'll save us $10 million if we have actuaries going over all the claims from the VCOs. Is that something that you see necessary, and why would that be needed if we stay on the VCO plan?
Mr. Whitlock.
Madam Co-Chair and Mr. Co-Chair. Maybe Juliet could answer that question. I don't recall seeing that specific line item in the budget, and I don't know that JFAC approved it.
It wasn't in the budget. It came after we killed the budget, then that proposal came forward.
Okay. I can't speak to that proposal, and I would just echo what Dr. McGrath indicated. We're at financial risk if we don't meet both the financial and the clinical outcomes that are prescribed in the contract. To me, that's incentive enough for us to make sure that proper claims are submitted, proper claims are reviewed, and proper claims are paid.
Just as a follow-up, the state's at risk of having to pay it.
Okay.
Madam Co-Chair and Mr. Co-Chair, again, if it goes and exceeds the per member per month that's targeted, we're at financial risk for that excess. Doesn't fall fully on the state. And Madam Chair, Co-Chair, if I could just, again, I want to put into context what we're talking about, because we talk about this $4.6 billion Medicaid budget, and that's total funds for FY24. We'll get a report next month from the department on what the actual expenditures were for the VCO in 2022, which spanned 2 fiscal years. But at the end of the day, what we're talking about, and this is my back of the napkin calculation, we're not talking about billions of dollars here. We're talking about probably, my ballpark figure is $600 to $700 million out of that $4.6 billion figure. And if you'll recall, a lot of the expensive parts of Medicaid are already spoken for. The behavioral health piece is now carved out. The dual eligibles are now carved out. We haven't done anything on pharmacy. The developmentally disabled can't go into a managed care program. So really what we're talking about is a very small component of this very large budget that rightfully you are very concerned about the growth of that.
We're out of time. I guess we're out of time. Just a quick question. If the VCOs saved us so much money, why was the request in the budget for an additional $600 million? Increase in Medicaid.
Mr. Whitlock.
Madam Co-Chair and Mr. Co-Chair, you mean for the FY24 budget? I don't think that can all be ascribed to value care organizations. I don't recall seeing a line item that said for VCOs we want to increase it $600 million. I think you're maybe looking at the total Medicaid budget, but again, I would defer to the department and.
All right. Thank you, Mr.
Thank
Whitlock. Okay, next we have Danny Jones from St. Luke's Health Partners. Welcome to committee.
Thank you. So good morning, co-chairs and members of the Managed Medicaid Task Force. My name is Danny Jones, Chief Operating Officer for St. Luke's Health Partners. We're a clinically and financially integrated network based in the Treasure Valley with approximately 4,500 providers spanning the entire continuum of care and primarily serving members across Southwest and Southeast Idaho for all lines of business and multiple payers. In addition, we also serve Medicaid beneficiaries across the entire state of Idaho through our Value Care Organization, or VCO. Our VCO is the largest in the state, with our most recent enrollment reflecting 112,167 beneficiaries. By way of comparison, this number has decreased from just under 150,000 in the February-March timeframe when the revalidation and disenrollment efforts went into place as a result of the public health emergency ending. I have been with Health Partners just over a year, and my background lends itself to a multifaceted perspective on managed care in general. In addition to working in a variety of healthcare roles for over 25 years, I'm also a mental health counselor by training, so I'm acutely aware of the behavioral health and social needs of the various populations that we manage. Prior to joining SLHP, I oversaw operations for 3 years at the St. Alphonsus Health Alliance, which is another CIN in the Treasure Valley, and VCO, from which one of my former esteemed colleagues will be speaking next. Prior to that, I helped to build and lead a CIN based in Southeast Idaho for 5 years, the Patient Quality Alliance, which is now also a VCO. Previous to that, I spent nearly 7 years on the managed care side working for Blue Cross of Idaho in both the medical management and healthcare operations departments, and most recently in provider services. I was the first employee truly dedicated to developing their value-based care strategy around partnerships with provider networks to offer lower cost products on the exchanges, with the strong belief that through network alignment and collaboration with provider-led organizations, we could offer a better, more coordinated healthcare experience at a lower cost for members, both in premiums and out-of-pocket expenses. This belief was the result of years and years of efforts on the payer side to attempt to manage costs through utilization management efforts like prior authorizations and other draconian-like processes to try and stop the pay-per-click mentality that had overtaken healthcare. There was organizational acknowledgement that these efforts had limited utility, created provider abrasion, and ultimately did not offer long-lasting or sustainable results in managing the total cost of care. Through many joint conversations with the provider community, the conclusion was that the only way to truly achieve cost containment and bend the trend on spend was to develop a greater collaboration with provider organizations, change the mindset away from fee-for-service, create a value-based care strategy that incentivized better outcomes and health through a range of incentive models while reducing costs and building a glide path for providers to take on the insurance risk, because all agreed that they were the best equipped to do so given their expert clinical decision-making to provide the right care at the right time in the right place. They also hold the trust of their patients more so than the insurance company and therefore have better ability to influence behaviors. I think we all acknowledge, similar to the current VCO model, that these partnerships are still very new in the scheme of things and have had some early successes, but frankly still need the time to mature and realize maximum benefit, especially given the dramatic landscape shift the hospital and provider communities experienced during COVID. While I am not here to badmouth insurance companies or MCOs, as I take great pride in the collaborative provider partnerships I helped to foster while I was employed by one, I am surprised that they would be perceived as an easy button to manage costs here, given the aforementioned realization that insurance companies or MCOs alone cannot bend the cost curve without resorting to the draconian processes, reducing fee schedules, applying benefit caps, using claims edits, and the like. Those only have the potential to restrict services and create further provider abrasion, which is the last thing we need today as we are still recovering from the Great Resignation, extreme caregiver burnout, and provider shortages. The VCO model has the potential to make a significant impact on the cost and quality of care because we're not only trying to manage the dollars, but we're also making tireless efforts to transform care delivery, facilitate clinical transformation, offer transparent data to our providers at the point of care to enable the right informed clinical decision-making and make people healthier. This is no small feat, and it certainly won't happen overnight, but it won't happen at all if we revert to payer-only driven methods and reduce the voice of the provider in managing the insurance risk. I would like to sincerely thank this task force for taking the time and making the efforts to garner as much insight as possible in order to make an informed decision on how Idaho proceeds with this effort, which I do hope is to maintain the value care organization model. I would be happy to entertain any questions.
Questions from the committee? Representative Tanner.
Thank you, Madam Chair. You had mentioned in the beginning of your presentation just about 150,000 people were under previously. With the disenrollment, you're about 112. I have some early numbers of 560 million of the VCO program that is currently what we're seeing. The final numbers will come up in September, but it sounds like this is pretty close to where it's going to end up. So when I look at that, that's about $3,800 per individual then at that 150,000. So would you expect, as we're at 112, we would see that same number kind of dissipate? So would it be a $35 million less, or do you think we're going to more hold true to the actual number? What are your thoughts on that?
Ms. Jones.
Thank you, Madam Co-Chair and Representative Tanner. I would assume, without having any of the information specific to the members who were disenrolled, their risk scores, their relative disease burden, that if we were on average to take that yes, we would expect a reduction in spend proportionate to the loss of that number of covered lives from 150 to 112,000.
Senator Cook.
Thank you, Co-Chair. Thank you, Ms. Jones, for being here today. Question for you. One of our biggest expense in the state right now is prescription drugs. In your mind and in your vast experience on both sides of the aisle on this debate here, can a VCO versus MCO help in prescription drugs in lowering our cost or getting that under control?
Ms. Jones.
Thank you, Madam Chair and Senator Cook. Pharmacy has been a difficult cost center for us to manage. I think there are certain levers from a clinical perspective that you are able to manage in terms of making sure that providers are prescribing generics, even in the generic realm, that they're prescribing lower cost generics, but you have to make sure that that cost transparency is available at that point of care when they're doing the prescribing. It has been limited because of PBMs and other very highly complex processes that are confounded by rebates and various other pieces that we don't necessarily have the levers to manage at the provider or the value care organization level. And so I think it really does depend on the structure that's put around that and what's available to us essentially within the realm of pharmacy benefit management.
Follow-up?
One other question is, another big cost that we have is our emergency centers. Mm-hmm. How do VCOs, I know we want to keep them healthy so they don't go to the emergency centers, but we have a whole bunch of frequent flyers that go to the emergency center. How do we get a hold of that using the VCO model versus the MCO model of helping those frequent flyers to quit going to the emergency center and go to their family doctors?
Ms. Jones.
Yeah, Madam Co-Chair and Senator Cook, I have a couple thoughts on that. One of those is ensuring that providers have visibility into who those frequent flyers or high utilizers are. And so making sure that they are aware of who those patients are, what their disease burden looks like, if they have unmanaged illness, if they've been seen recently by any other providers, to make sure that they are able to do proactive follow-up and outreach to those individuals to try and educate about appropriate utilization. The other part of that is we've had extreme access to care challenges, and I spoke to that a little bit when I talked about the Great Resignation, provider shortages, and provider burnout. And so I think it's quite evident that we are not going to recruit our way out of this problem. We really do have to focus on clinical transformation and a different way of delivering care. And so rather than putting that entire burden on an individual provider or primary care PCP, we really need to come around developing appropriate care teams and leveraging other resources across the continuum to make sure that we are addressing the specific needs of those patients. Sometimes it's not a physician that they may need. It might be a community health worker that's going to help them, understand where they can access, good healthy food, or get transportation to appointments so that they're not waiting until after hours to go to the emergency room. So really, our focus has been on how do we develop that care team model to take some of that burden off of providers, improve access to care just in general for patients, to make sure that they are not using that last resort and most effective, or excuse me, most expensive care setting in the emergency department.
No more questions. Thank you, and thank you for being here today.
Thank you very much.
Okay, committee, we're going to take a lunch break right now. And if we can be back here at 1:30, we'll get started again with the rest of our presenters for this afternoon.
All right, you heard Senator Van Orden. They are going to take lunch now, and we're going to conclude our live stream now. For any of you who have watched the whole thing, congratulations, you are informed. If you want to follow the rest of the committee hearing, go to the Idaho Legislature website, go down to the digital streaming, and they're in House Hearing Room EW 42. And you can find that you can even, I think on the bottom right corner of the Legislature webpage, it has a link directly to that committee hearing because it's a special meeting. So yeah, if you're interested, go do that. Check out our YouTube, Twitter, Facebook, and Rumble channels. I have uploaded Niklas's testimony in case you want to go back and see it again. I feel like I just have to say it was kind of underhanded for Representative van der Woude to respond to something that Niklas said after he'd already sat down, and so he couldn't respond in kind. About the Idaho Department of Health and Welfare shutting down their process of removing ineligibles. Van der Woude is right that they had been doing that, but what Niklas explained is that they stopped doing that because of some issues with federal bureaucracy. So hopefully we'll have a chance to go into more detail on that soon. In just a few minutes, Niklas is going to come over here to our studio, and we're actually going to record this week's Fiscal Fridays. One of the other people who testified this morning to the committee is going to be our guest, and so we'll get that interview recorded and we'll have that up for you on Friday. Again, go to idahofreedom.org to see all our content. Follow us on YouTube, follow us on Facebook, follow us on Twitter, and